Morning, respected chairpersons. I'm from CMC Vellore. We had an interesting case which we did 8 months back, in which we used only CO2 as a contrast. Coming to the clinical details, this was a 30-year-old lady from local lady who presented in November 2012 with acute onset dyspnea for 5 days duration, associated with orthopnea and PND for 1 day. No known prior comorbidities. Pulse rate slightly tachycardic, regular. BP right upper limb was 240 by 126. And left upper limb pulse was weak. Right lower limb it was 250, 134, and left lower limb was 246, 140. And cardiovascular system examination, there was an S3, no murmur, and respiratory system, there was bilateral crepitations were present. CNS examination, there was no focal deficit. She had bilateral mild papilledema which was present. And abdomen examination, there was bilateral renal artery bruit. Investigations were markedly, what was striking was hemoglobin was normal, creat was quite high with a urea of 121, more like a pre-renal. ECG showed LVH strain pattern. Echo showed LV global hyperkinesia with EF of around 35%. Cardiac enzymes, CKMB was, serial enzymes were slightly elevated. Troponins also went up to 576. LFT TSH was normal. Her immunological markers were high. ESR was 50 and CRP was 53. Autoimmune panel was negative. Infectious markers were negative. And the initial endocrine workup for secondary hypertension otherwise was negative. And since there was a renal bruit, we proceeded renal Doppler, which shows bilateral RAS, renal artery stenosis, but importantly, normal size kidneys. So at this point, our clinical diagnosis was a large vessel vasculitis because she had a missing left upper limb pulse, so probably a tachyarthritis with bilateral renal artery stenosis, clinically a left subclavian artery lesion, and she was in a hypertensive emergency with LV failure, and she had early papilledema as well, and she had acute pre-renal failure, and also acute myocarditis with severe LV systolic dysfunction. So her course in the hospital, she was intubated, started on IV nitrates and Lasix. She needed almost 6 antihypertensives to control her BP. And on the first day, she needed 1 session of hemodialysis, but subsequently she was putting 600 to 800 ml of output of urine. She was taken up for a CO2 angio, followed by intervention on day 3 using no contrast in view of her renal failure and to preserve her kidney function. So this is a CO2 abdominal angiogram, which was done. I don't know how many of you can make out, it's not very clear, but this is a pigtail angiogram using CO2. I'll come to a still image. On the left side, you can see that the white stuff which you see is the renal artery, and that's stenosis. And right side, you cannot see anything because the right renal artery is occluded. We proceeded with an intervention. The sheath which we used was initially a short sheath followed by a long 7F sheath. And the guide wire used to cross the lesion was a 035 Terumo guide wire within a JR catheter. Stiff wire was Amplatz super stiff wire, and we pre-dilated both the lesions with a non-compliant Conquest 520 balloon. And here, because she was a local patient and she was in the ICU, there's a lot of expense. So in order to cut the expense, what we did was we used a Abbott Jomet Petful stent, 6 to 9 to 28 mm, and we manually cut it into 2 halves, each of 14 mm each. And each half was crimped on a 6 into 20 Conquest balloon and deployed at 10 atmosphere. So this is both the stents being deployed. The first we deployed was the right and the second was the left. And both of these were Jomet stents, which was 128 mm cut into equal half of 14 mm and deployed on a 620 balloon. And this is the final CO2 angiogram. Now you can see the result much clearly, in which you can see the both good flow into bilateral renal arteries and also the renal branches. Now post-procedure, within 2 to 3 days, her BP got controlled and antihypertensives were tapered to just 1 at discharge from 6 in the initial. Renal functions dramatically improved and creatinine reached normal value of 1.0. Her pulmonary edema settled, and as is a practice in our center with tachycardia, we started on immunosuppression with mycophenolate mofetil and steroids, and she was discharged in a stable state. We had a 6-month follow-up. She was clinically doing well. ESR was 22, CRP was 10, and BP was 134/84 on just 1 amlodipine 5 mg/OD. Creatinine 0.8 and echo also reverted normal. Ejection fraction came back to 58%. There was no regional abnormality compared to earlier, which was EF was 35%. This was the follow-up renal angiogram, which showed a very good result and no problems, excellent flow in the renals, and important to see a good nephrograms on both the sides. There was an infrarenal aortic lesion which was not having a gradient across, so we did not intervene for that. We did an arch angiogram also because she had left upper limb pulse which was missing. And as you can see, after the left vertebral, the subclavian is occluded in both LAO and RAO views. and we proceeded with an intervention for the left subclavian. We put in an APVIC self-expanding 18 to 40% scientific stent with very good result and good flow down the arm and into the left vertebral artery. So I would like to conclude by saying that CO2 guided intervention, especially for renals, mesenteric vessels and iliac, is an option for patients having renal dysfunction, and innovative techniques like in our case of stent to 2 may help save the cost. Thank you.
Thank you very much. We have 1.5 minutes for questions. Thank you, Dr. Verghese, for keeping to the time.
One thing I wanted to ask you, we are used to, wiring and putting balloon and stent under contrast media. So is it difficult or?
No, the clarity in this is not very good, but it's slightly better. And the whole thing we did just using CO2, not even one drop of contrast was used. So wiring, everything was done with the routine glide wire, everything using just contrast guidance. I mean CO2 guidance, no contrast at all.
And out of curiosity, how do you inject CO2? I mean,
we have a system, a homemade system, which Dr. George Joseph has ingeniously made in our place. The official actual system comes to few lakhs, but this is a local system which is made out of blocks, and we need a cylinder of CO2. And a set amount of carbon dioxide is injected at each injection. And this is a locally made system which I had made some 10 years ago. I think it was around 10,000 rupees only for the system.
What you use? We have done the similar case by using carbonated liquid, means the bottle which comes with the carbonated soda water. We sterilize it in the autoclave and then take out some of the soda water, and then we just shake it, and there we put a sterile needle. With that, we connect with the 3-way, take out with the syringe, and then inject the 3-way port, and then we inject. So we made ourselves. It doesn't hardly 15 rupees. It costs 15 rupees. You have to sterilize. That's all. We have done in our hospital.
no, because carbon dioxide cylinders are easily available, but how to inject it and how to use it, that is the.
You have to first autoclave it. And after autoclaving it, take out some of the fluid, throw it out, reclose it, and then put a needle and throw that needle, connect with the 3-way, take out the 10 ml, because otherwise if you will connect to the port, hole will go inside. So you take out 10 ml syringe, inject with each syringe with the 3-way port.
How are you ensuring the stability of carbon dioxide while using it in the cylinder? In the cylinder, it may not be sterile.
Yeah, that is one thing that we cannot be absolutely sure of. But then we connected to a system of, we have a separate block system which delivers a certain amount of carbon dioxide.
There is no way to sterilize.
No, there's absolutely, in this particular thing, there's no absolute way to sterilize.
Can you pass on the mic there at the back?
Yeah, one question, please. Technical question here. Yeah. When you cut the stent,
Geomed peripheral
cut
stent.
the stent in 2 parts, how do you ensure the smoothness of the edges? And,
what we did was
and the integrity of the smoothness.
Yes, what we did was the flared out or the cut edges, we left it projecting into aorta, and the smooth end was left inside the renal. That's what we do in such cases.
Can you pass on the mic there for a minute?
I have it here.
Yes.
The only comment, if you haven't used CO2 for angiography, it's only good down to about the level of the femoral vessels. Below there, you really lose detail, and it would be, I think, a mistake to operate on findings below the inguinal ligament. I find it very difficult to determine detail at that level. In the abdomen and pelvis, it works very well.
Thank you very much. That was the last question, and thank you very much, Dr. Verghese.